Welcome to educational session number 10, Immunotherapy. My name is Heather McArthur. I'm the clinical director of the breast cancer program at UT Southwestern in Dallas, Texas. And it's my extreme pleasure to be chairing this session today. We have an outstanding set of lectures today and a really terrific program. So without further ado, I'd like to invite Cesar Santamaria from Johns Hopkins Medicine, Baltimore, Maryland, who's going to talk to us about immune therapy for early ER-positive breast cancer. Welcome.
All right, thank you very much, Heather, and thank you to the organizers of the event for inviting me to talk about immunotherapy and ER-positive breast cancer. So we'll jump right to it. These are my disclosures. I'll start by just giving a little bit of background and introduction, our initial experience with immunotherapy and ER-positive breast cancer, and highlight some of the tumor microenvironment features of ER-positive breast cancer. And then we'll talk a little bit about the differences in approach to luminal A versus luminal B like ER-positive breast cancer from an immunotherapy perspective. So why immunotherapy for hormone receptor-positive breast cancer? It's the most common subtype of breast cancer, and endocrine therapy has historically been the cornerstone therapy. However, patients with early-stage disease can still recur with conventional therapy even years or decades after diagnosis. And when metastatic endocrine therapy resistance almost universally occurs. And while endocrine therapy certainly is generally more tolerable than immunotherapy, it can have its own toxicities which can affect quality of life over outcomes. So a lot of research to improve treatments for patients with hormone receptor positive breast cancer have focused on targeted therapies against common resistant pathways, but still novel approaches are needed, and the case I'll make is that immunotherapy may have a role. So our initial experience with immune checkpoint inhibitors in metastatic ER-positive breast cancer, at least, was not very good. So several studies looking at single-agent immune checkpoint inhibitors, such as Keynote-028, which treated patients with later-line metastatic ER-positive breast cancer with pembrolizumab, showed low response rates. A small study looking at durvalumab, where we looked at ER-positive and triple-negative patients. We saw some patients with triple-negative breast cancer could benefit, but unfortunately, none of the patients with ER-positive breast cancer did. In a randomized study in more of a heavily pretreated metastatic ER-positive population of eribulin plus minus pembrolizumab, failed to show any improvement in progression-free or overall survival. So why were these initial experiences not as favorable? Well, it's really important to look at the differences in the tumor microenvironment in ER-positive breast cancer. Some of the clinical biomarkers we usually think about for immune sensitivity, such as PD-L1 or TNB, are lower in ER-positive breast cancer. So you can see in the left-hand figure, relative to HER2-positive and triple-negative, PD-L1 expression tends to be lower. And on the right figure, you can see compared to triple-negative and HER2-positive, average TNB is lower in ER-positive breast cancer, although the proportion of hypermutated patients is actually similar across subtypes. The story of TILs in early-stage ER-positive breast cancer is really interesting. Generally, there's lower tumor-infiltrating lymphocytes in ER-positive breast cancers, but as you can see in the figure in the highlighted area in the ER-positive patients, the higher the TILs, the higher chance of a pathologic complete response to neoadjuvant chemotherapy. Similar relationships in the other subtypes of breast cancer. However, this doesn't necessarily translate to an improvement in survival endpoint. So you see that patients with higher TILs tend to have a higher risk of recurrence. And why that might be. So ER-positive really is, breast cancer is a really heterogeneous disease. And we classically think about it in terms of endocrine therapy sensitivity along the spectrum of luminal A versus luminal B, with luminal A being your more indolent, high ER-PR expressing tumors, lower Ki67, lower gene expression scores, but they also tend to have lower PD-L1 TILs, TNB, and a colder immune microenvironment. Luminal B is essentially the opposite. And this can inform a little bit about some strategies from a translational perspective in developing immunotherapy approaches. So CDK4/6 inhibitors are agents we obviously use a lot of in the early stage and metastatic setting. We use them mostly for their cell cycle activity and synergy with endocrine therapy. However, they have various effects on the tumor microenvironment in terms of antigen presentation and also in T-cell recruitment and activation. CDK4/6 inhibitors can increase MHC class 1 and 2, type 3 interferons, increase cytokines resulting in T-cell recruitment and memory, and increase T-cell activation. In fact, several in vivo models have shown consistently across different models that the combination of CDK4/6 inhibitors with PD-1 or PD-L1 inhibitors can have synergy in terms of having tumor suppressive effects. And there's clinical data also that provides evidence that they can have CDK4/6 inhibitors can have tumor microenvironment modulating effects. So in the NeoMonarch trial, this was a neoadjuvant study of anastrozole and abemaciclib. There was a window portion of where patients were randomized to anastrozole, to abemaciclib, or to the combination of both drugs. And what was really interesting is they had biopsies before and after. In the combination arm, the abemaciclib and anastrozole arm, there was upregulation of interferon gamma, antigen processing, cross-presentation genes, and PD-1 signaling genes as well. So we conducted a neoadjuvant study termed the Immunoadapt study to better understand the relationship of how CDK4/6 inhibitors can modulate the tumor microenvironment and how that may or may not translate to responses. So we randomized patients with stage 2 and 3 ER-positive breast cancer to get endocrine therapy followed by avelumab with or without palbociclib. And we used a staggered approach, as you can see on the schema, where only after cycle 1 was the avelumab added. We had tissue biopsies at baseline at cycle 2 and collected tissue from surgical samples. We also had an MRI at those time points. What we saw was after the first cycle of treatment, in terms of radiographic response, there was no significant difference between the endocrine therapy or endocrine therapy palbociclib arm. And this is actually similar to other studies that have looked at neoadjuvant endocrine therapy with or without CDK4/6 inhibitors. The response rates aren't necessarily different. However, when we added the avelumab, you can see that there was a divergence of the arms, with the CDK4/6 inhibitor arm having a greater response. This translated to an overall response rate of almost 43% on the CDK4/6 inhibitor arm compared to 11% on the control arm. This particular regimen was well tolerated with 10% grade 3 immune-related toxicities. We had one patient with hepatitis and colitis in the CDK4/6 inhibitor arm. We're undergoing our translational program spearheaded by a phenomenal fellow at Hopkins, Dr. Zavras, who's just yesterday presented some of our spatial transcriptomic analysis. And so far what we're seeing is recapitulating some of the earlier data where we see increased expression of immune activation genes in the CDK4/6 inhibitor arm after 1 month. So increasing the antigen presentation, T-cell activity, recruitment, and memory. There was a metastatic study with a very similar combination in a different clinical setting. So the PACE trial was a randomized study in patients who were refractory to initial CDK4/6 inhibitor. They were randomized to fulvestrant plus palbociclib, or an exploratory arm of fulvestrant, palbociclib, and avelumab. Progression-free survival was similar in the fulvestrant and fulvestrant palbociclib arms. However, in the exploratory avelumab arm, the PFS improved by almost 4 months. So from 4.6 in the fulvestrant palbo arm to 8.1 months. A similar relationship was seen in terms of overall survival. So similar overall survival in the fulvestrant and fulvestrant plus palbo arms, but the fulvestrant avelumab arm had almost a 20-month improvement in overall survival. This particular regimen was also well tolerated with less than 15% grade 3 immune-related toxicities. And that's an important point because several other studies have actually been conducted with these combinations, and other CDK4/6 inhibitors, particularly with PD-1 inhibition, have higher rates of immune-related toxicities, particularly hepatitis and pneumonitis. So I think more research to be done in this arena. All right, so switching gears to luminal B breast cancer. So these are more inflamed, more triple negative-like, and our initial experience with chemoimmunotherapy in the neoadjuvant setting that came out of the I-SPY 2 study gave us a signal in ER-positive breast cancer. So we usually think of a significant improvement in PathCR in the triple negative cohort, but there was also a significant improvement in PathCR in the ER-positive cohort with the addition of pembrolizumab to standard neoadjuvant chemotherapy. Last year, we got results from a couple of really important larger studies, the Checkmate 7FL study, which was a study in stage 2 and 3 ER-positive breast cancer that was grade 3. Patients were randomized to standard chemotherapy, ACT plus minus nivolumab. The primary endpoint of this phase 2 study was PCR, and they saw an improvement in pathologic complete response rates from about 13.8% to 24.5%, but in the PD-L1 positive subgroup, the PathCR rate was much higher at 44.3%. They also presented last year at San Antonio a really nice translational analysis. They looked at PD-L1 status. They noted that the prevalence of higher PD-L1 status was lower than lower cutoffs, but importantly that higher PD-L1 status was associated with pathologic complete response in both arms, in both chemo and chemoimmunotherapy arms. But there was an increased association with nivolumab benefit. So if you look at the delta between arms, it also increased with PD-L1 positivity. Tumor-infiltrating lymphocytes were also examined. And again, as other studies have shown, higher tumor-infiltrating lymphocytes are associated with higher PathCR rates in both arms, but there was no difference in the net increase of nivolumab benefit with increasing tumor-infiltrating lymphocytes. Estrogen receptor and progesterone status were also associated with higher PathCR, so the lower ER-PR expression, the higher PathCR rate, and Ki-67 was not associated with nivolumab benefit, although it was associated slightly with higher PathCR rates. And then we got the results from the larger Keynote 756 study, which is a registration study of patients with stage 2 and 3 ER-positive breast cancer who had centrally confirmed grade 3 disease. The primary endpoints here was not just PathCR, but event-free survival as well. And last year at ESMO, we got the results for the PathCR data showing increase from 15.6 to 24.3% in terms of PathCR rate. There was benefit to adding pembrolizumab in stage 2 and 3 disease, as you can see on the left. But a lot of this was restricted to patients who were lymph node positive. Not much difference in the lymph node negative patients. And then also PD-L1 status was examined, and again, PD-L1 status is associated with higher PathCR rates, but also associated with a greater pembrolizumab benefit, potentially poising this to be a predictive biomarker. Benefit was noted to be highest in patients that were ER low, particularly if they were PD-L1 positive. So going back to some of the I-SPY data, looking at chemotherapy and immunotherapy in the neoadjuvant setting, MammaPrint has been is an entry criteria for these patients, and the highest scores of MammaPrint high, termed MammaPrint high 2 or ultra high, these patients were found to have very high PathCR rates, almost approaching what you see in triple negative breast cancer, up to 60%. And this, there was a very nice analysis presented at ASCO this year, explaining part of the reason why this might be. MammaPrint high 2 is associated with increased innate immunity, upregulation of antigen presentation genes, higher PD-1, PD-L1 expression, and increased adaptive immunity genes as well. This has led to the development of the SWOG 2206 study. This is a study that's actively opening and enrolling. So this is for patients with stage 2 and 3 ER-positive breast cancer who have mammaprint high 2 disease. Mammaprint can be ordered as a standard of care or as part of the clinical trial through a consent process. And if patients are confirmed to have mammaprint high 2, they're randomized to standard of care chemotherapy with or without the PD-L1 inhibitor, durvalumab. All right, so in conclusion, ER-positive breast cancer is an immunophenotypically heterogeneous disease. And luminal A breast cancers really are immunologically cold. They usually don't have much in the way of immune cells infiltrating. However, strategies, if you want to think about immunotherapy, require a reprogramming of the tumor microenvironment. Luminal B breast cancers are, relatively speaking, more immunologically hot, and the addition of immune checkpoint inhibitors to neoadjuvant chemo may be helpful in some patients. And I think it's really important to be careful to avoid overtreatment. ER-positive breast cancer is still a very curable subtype of breast cancer, and we need to be careful in exposing patients to the toxicities of immunotherapy. All right, that's all I got. Thank you.
Thank you so much. And just as a reminder, we will have a Q&A session at the end of the 3 speakers' talks. So please hold your questions until then, or you can submit them online as well. Next, I'd like to invite Dr. Marleen Kok from the Netherlands Cancer Institute in Amsterdam, Netherlands. She's going to talk to us today about optimization of treatment for triple-negative breast cancer. Welcome, Dr. Kok.
Thank you, Heather, for the kind introduction. Thanks to the organization to giving me the opportunity to discuss the optimization of immunotherapy for early-stage triple-negative breast cancer. I will focus my talk on the early stage because there are enough challenges to discuss there. I think, this is a topic where we could spend like the whole meeting on, and I picked out some elements I think that are of high priority. These are my disclosures. So I phrased, while preparing my talk, kind of, 3 educational objectives that I think we should focus on in the future as investigators. I think it's very high importance to understand who are the patients that we really cure by adding pembro. So if we didn't add pembro, they would have died from the disease. And that's like really a life-saving treatment. Second point of my discussion will be, can we give less intensive treatment? For example, can we not give the full year of pembrolizumab, or can we give less chemotherapy in those that are really sensitive to immunotherapy? Last but not least, now that we cure more of our triple-negative breast cancer patients, young women, we need to study the impact on the long term of immunotherapy, on their quality of life. Let's start with the first. So these data we've seen at ESMO. It's wonderful that the addition of pembrolizumab gives us overall survival for our patients. And as said, it's 5%, so 4.9% survival benefit. So we cure an extra 5% of our patients. So I think it's an urgent need to define those 5% instead of treating everyone and hoping that those 5% are in that population that all receive the treatment. I would like to discuss with you the biomarker data that we saw at the first day of San Antonio. Wonderful to see the data, but I think there was a lot in the presentation, so I had to highlight some of it. So these are the data presented on a T-cell signature. A T-cell signature, and they made a distinction like the lower 1/3 and the other 2/3. And you see here that at least with this T-cell signature, with this cutoff, it's not that you can tease out the ones that benefit from pembrolizumab, but remind you, it's only 5% that really need this drug. So maybe if you have, this category of immune signature, it's not the right way to study this gene signature. Also, I think very interesting that we saw the triple-negative subtypes. And what stood out, at least for me, is this luminal androgen receptor subtype, where what we consider in general like a cold tumor. Here you see a great benefit of pembrolizumab, kind of unexpected and great to have these data. But at your left, you see BLIA, basal-like immune activated. There, it's exploratory, of course. You see that the benefit from pembro is limited, if there is any benefit. How would that happen? So is this a group that is highly infiltrated, so immune activated, that you cure them by chemotherapy? It's of course hypothesis generating. And then we saw this complicated table. So this is at least the way I try to interpret it. So at your right, you see the signatures in the chemo-treated group, and more at the left, you see the signatures performing in the chemo plus immunotherapy group. And you would like to see different statistics, somewhat a biomarker that is not giving information in chemo only, but that gives information in IO plus chemo group. And you see a few of them there, like the myeloid-derived suppressive cell gene signature. So myeloid-derived suppressive cells are like bad immune cells, so to say. And it's a red square, meaning if you have a higher signature, probably less benefit of pembro. And the same for the stromal, epithelial mesenchymal transition, TGF-beta. From other cancer types, it's well known that TGF-beta is not a good thing to have for your immunotherapy response. So very important data. But then, of course, there were brilliant questions from the audience and online. Where are the TILs? Right, that's an H&E, that's available for all. It was not in the presentation, and I think that was at least a disappointment also from the questions that were asked. Also, a very good question from Fraser Simon, was there a test for interaction? You can see a difference and a difference, but a test for interaction, you say, is this different? And that was lacking from the presentation. And then I would like to, this complicated thing with all the signatures. So I was wondering, is this the right cutoff? Also, the data were adjusted for the T-cell signature. You can wonder why that was the case. And then I think it's important to see a follow-up with those that have high gene signatures for myeloid-derived suppressive cells, TGF-beta. Is it the case that they really didn't benefit from pembro? Was it still, a relevant benefit? So I think we need to see those data. But wonderful that this presentation was here at this meeting. Going back a few years, the Gepar-Nuevo study already reported TILs. So Gepar-Nuevo with durvalumab, anthracycline taxane, there was no carboplatin given. But you see here, let's point it, do we have a pointer? Yeah? Oh, it's not working, the pointer. No, let's do it way down. But you see in top,
Oh, there it goes.
oh yeah, there is. No, it's not. It's only on our screen. So it's a fake
It
pointer.
was there for a second.
Oh, yeah. Okay, but I'll guide you through it. So you see that the TILs, at least at these cutoffs, were not discriminating for durvalumab benefits. This is informative, but a slightly different regimen. And the cutoffs, you can, of course, argue whether those were the right cutoffs, but important piece of data. Then last San Antonio, we saw real-world data sets. Of course, small data sets, real-world, not randomized. But I think it's important to review them. So you see at your left, you see the data for patients with high TILs, above 50%, and at your right, low TILs. And they included three types of data sets, like anthracycline taxane, so non-carboplatin, then the carboplatin group, and then pembro, meaning pembro added on top of regular chemotherapy. And you see different patterns for high TILs. So what this, could suggest that in the high TILs, there's a pembro benefit, while in the lower TIL group, not a significant pembro benefit, small numbers, but there the carboplatin was yielding much. So this tells us that the TILs could be important, depending on the backbone of chemotherapy, of course. Then making it a bit more complicated, but I think this is a very elegant study from the NeoTrip immunotherapy trial, neoadjuvant setting. And here you see spatial data, so tissue imaging with about 40 markers, and you see black dots and red dots. So red dot means it's informative in the group treated with chemotherapy plus immunotherapy, and the black the control, so only in chemotherapy. So an interesting marker, you would see like a split between the dots. And you see statistics as this test for interaction, as I just explained. Is this different, really different? And you see interesting result, but the only, significant finding here was PD-L1 on antigen-presenting cells. This is interesting, right? So the PD-L1 in Keynote 522 was not a biomarker to dissect who needs pembro, but if you do more specific analysis on PD-L1, so on the antigen-presenting cells, there is information. And in this paper, they even made it more complicated by measuring the distance between an immune cell and a cancer cell. And here you see way more, statistical findings. So the spatial orientation where the immune cell is important. And you see at the bottom CD20, a B cell marker. So B cells very close to the cancer cell is a good thing to have. It's a question whether it's really functional important or whether the B cells are a bystander effect. But you also see that granzyme B, for example, is important, and again PD-L1. So this information, though complex, provides the information maybe who needs the immunotherapy. This is a small proof of concept study from my institution where we treated with immunotherapy alone. In a highly selected group, groups received 4 weeks of anti-PD-1, nivolumab, and also a group treated with anti-PD-1 and anti-CTLA-4. And here you see that the TILs were predictive of response as well as PD-L1. But there was also a very clever master student that came up with the idea to measure the distance between the CD8 and a tumor cell. And this is not this complex analysis. This is one H&E with an algorithm. And a low score meaning the T cell is close to the tumor cell. You see a massive difference. So this could be, something that could be implemented in the clinic if validated in larger studies, of course. And then I would like to draw your attention, it's a bit of a sneak preview for the poster spotlight that will be after this session, on the acquired resistance. Right? If you think about responders in the metastatic setting, but it could also well be the case in the neoadjuvant setting, there's this problem of acquired resistance, and that is a big problem in the metastatic setting. And here we have a data set of metastatic triple-negative breast cancer, and we try to see primary resistance versus acquired resistance. And you see here the T cell patterns. So at your left, the primary resistance patients, lower in CD8 than the ones with an acquired resistance, making sense. But then in the acquired resistance, you see upon response an increase in CD8, but at acquired resistance, a drop. So, and this you won't find at baseline. So I think we need to do more studies on the acquired resistance to really personalize the treatment. And also things like that are informative for the antigen presentation machinery. You see here in acquired resistance lower in MEL2. So MEL2 regulates the antigen presentation machinery. So you should have it at low. But here you see the patients with acquired resistance, you see an upregulation. So better understanding of the complex antigen presentation machinery is important. Also, I think, for biomarker development. So to conclude the first part, there's still a lack of biomarkers to predict the ones that we really cure with pembrolizumab. With growing number of treatment options, with the ADCs in the post-neoadjuvant setting, we should rethink in the way how we do trials. That not the biomarkers come 5 years later, but the biomarkers should go hand in hand with the primary results and make the biomarkers mandatory. There's a role not only for pharma, but also a role for FDA, EMA, and even guideline committees. That if the biomarker is not coming from the pivotal trial, but enough from academic work, we cannot ignore all the academic signals that we are creating together. The biomarkers can be predictive, as I just showed you, but they can also be simply prognostic. A predictive biomarker is very difficult. It has been shown by historic data in the breast cancer field, but prognostic biomarkers are usually a bit easier. I will show you how a prognostic biomarker can help deciding do you need treatment or not. And this is applying to stage 1 triple-negative breast cancer. Of course, we don't treat with immunotherapy. But this is how it looks if you think about chemo benefit in stage 1. Retrospective data, that's the only data we have. And you see no benefit for PT1A and B, and minimal benefit for PT1C, while all of us give the chemotherapy for this 3%. So can we dissect those with triple negative with a good prognosis? This is a recent example on TILs. There are now plenty of papers. Just want to show you here analysis on the PT1Cs, because that is the group that we would give chemotherapy. Like here you want to dissect more. And you see on top the green line, those with high TILs. And this is historical data. Patients didn't receive chemotherapy. And you would all give chemotherapy to those in green. That's massive overtreatment. So can we use the TILs to tailor treatment for stage 1 triple-negative breast cancer? There are now 2 prospective trials launched in Europe. One is initiated in the Netherlands, the Optimal study, where for patients with high TILs, 50% cutoff for above 40, for very young women, a cutoff of 75%. It's a patient preference trial. Because if you first explain your patients, you will have an excellent prognosis, and then you randomize, the trial won't fly, at least not in the Netherlands, where people tend to be very critical. So it's up to the patients, and we try to balance the treatment groups. The ETNA study, that is also open in France and Spain, slightly different approach. So if the TILs are intermediate, patients opt for paclitaxel and pembro, and at the bottom you see also an observation, so no chemotherapy for TIL very high. Those initiatives based on a prognostic biomarker, tailored treatment. Let's go to the next subject. Can we give less intense treatment without compromising survival? So this is the design, of course, from Keynote 522. In my view, it's really a lack of this second randomization. If this trial would have been designed that after surgery, based on your PCR or not, another randomization on do you need adjuvant pembro or not, we would have had this information. And that we would have known what is the contribution of the adjuvant pembrolizumab. But we don't have those data. If you review the curves, and this is most recent overall survival data for the PCR patients, you see that a PCR with chemotherapy, the survival is almost as good as the survival with chemoimmunotherapy. So is there a pembro benefit in patients with a PCR? If there is one, it will be very minimal. And if you would have, say, 1% benefit in a primary trial, you will consider it a negative result, I would say. You see that the curve split for the non-PCR patients, which was, I think, when we saw this for the first time, a bit of a surprise. But my take on it is that you get a different residual disease. So the residual disease probably contains a lot of TILs after immunotherapy, and thereby you have an active immune response. There are trials where there was no adjuvant immunotherapy used. Here, again, you see the data from the Gepa Nuevo. In pink, you see the patients with a PCR. And remember, no, only neoadjuvant durvalumab and chemotherapy. Survival is excellent without adjuvant immunotherapy. Same goes for the NeoPact study. A study where carboplatin, docetaxel, and pembro was given, only neoadjuvant, no adjuvant immunotherapy, and again, with the PCR, patients do great. We know from other tumor types, we know way more on this neoadjuvant versus adjuvant contribution. This is an elegant study coming from the melanoma field, randomized between neoadjuvant versus only an adjuvant regimen. And you see a big difference in melanoma. That in the neoadjuvant setting, immunotherapy has way more chance to recognize the cancer. So at the top figure you see, if you first take the tumor out and then you treat with immunotherapy, you might get a bit of T-cell recognition because there are a few micrometastases. Well, at the bottom, you have the tumor there. The T-cells have a way easier job to recognize the cancer cells, and it results years later in a better, more favorable T-cell repertoire. It's good to see that also the FDA is now reconsidering trial designs, and that a trial where you have neoadjuvant and adjuvant is probably, I would say, not going to happen, but at least to a lesser extent. So trials will become more complicated, 3-arm, 4-arm, but there are, in the pivotal trial, you have additional information on duration of treatment. And it's glad to see that there are academic initiatives over thousands of patients, so a lot of resources necessary for patients with a PCR randomizing between immunotherapy or no immunotherapy, both in the United States as well as in Europe. Then a bit on patients with a non-PCR. And here you see the curve split out by RCB, residual cancer burden. And it's a huge difference, right? This group of non-PCR patients is really a mixed bag. It's important to note that in this trial, there was no adjuvant capecitabine or adjuvant olaparib. So how would the data have been looking if that was given? So a better control arm, so to say. So that's an open question. For those with an RCB2 and especially in RCB3, there is really an urgent need for a different treatment. So not only the adjuvant pembro question is relevant, but should we treat them with ADCs? Trials are ongoing. I think also an open question. If you come in with another immunotherapy approach, do we have a chance? But don't forget that you have been treating for 5 months with toxic chemotherapy. Your T cells are not at best in this setting, so that might be a limitation for novel immunotherapy. And then if I would make for Christmas a wish list of things that we would learn all together, this one would be on my wish list. Is there a way at baseline to predict those patients that will end up with an RCB3 and that we don't, get this information after 6 months of treatment, but that we have the information right away? And basically after maybe, you try 1 or 2 cycles, but then you give your experimental treatments to change the survival of these patients with a very poor outcome. I highly recommend reading this editorial. It came out in the New England together with the paper on the overall survival from the Keynote 522 by Hal Burstein. He phrases like the Keynote 522 trial deploys a maximalist 4 chemo regimen. And I think he phrases very nice that you have to realize that the chemo backbone that you're giving together with immunotherapy now is a lot of treatment. So recall how history went for HER2 positive. I think when I was still, in high school maybe, that HER2 positive was a devastating disease. And now it's the breast cancer subtype with the most favorable prognosis. And I think anthracyclines are hardly used anymore. So can we follow the path of HER2 positive to go to, in a selected group of patients maybe, give anthracycline-free chemotherapy? And here again you see the NeoPact study, a relatively small study with anthracycline-free chemotherapy. If you reach a PCR, patients do great. Last year here at San Antonio, we saw the NeoN trial with Nivo given with carboplatin and paclitaxel. And if you look here at the PCR rates, can be super high, especially in those with a PD-L1 positive or high TILs, suggesting that you don't need anthracycline for a selected group of patients. And happy to see that here in the US there is a larger trial running, the SCARDA trial, with anthracycline-free chemotherapy to address this question. And I think it's important to really follow up on these academic trials and see whether they can really change the guidelines. Can we even take it further? Can we select patients that are highly inflamed that we can cure with immunotherapy? This is only proof of concept to see what happens if you treat with immunotherapy alone. So 15 patients, node negative, all till above 50%. We've been treating them for 6 weeks with anti-PD-1 plus a low dose of anti-CTLA-4. And you see that with only 6 weeks of treatment, 1/3 of the patients already have their PCR. And this you have to compare with the 5 months of chemotherapy plus IO. Though I have to say that 3 out of the 15, so 20%, had an adrenal gland insufficiency, which, not according to protocol, but my personal opinion, is very high because this is a lifelong toxicity. So to see whether a less toxic regimen can also benefit patients, the next cohort, and we presented it at ESMO, again, highly inflamed triple negatives, 8 weeks of anti-PD-1 plus anti-LAG-3. And you see that the PCR rate goes up to 47%, remind you, small numbers. The toxicity profile seems to be better, but we have to wait until we have more follow-up. But again, this is proof of concept on are there patients where we can treat and hopefully cure with immunotherapy alone. In this trial, we also analyzed the ctDNA. And you see here that 24% after 4 weeks cleared ctDNA. And ctDNA clearance is a beautiful prognostic marker. So can this be used to tailor treatment? Start with IO only or start with chemotherapy only and not do this Keynote 522 maximalist treatment in everyone. Of course, it's a small trial, but if you look at the I-SPY data and triple negative, in yellow you see ctDNA, over time, and already at the second time point after 1 cycle, you see that in patients in yellow reaching a PCR, your ctDNA is gone. But now we keep on treating, for 4 additional months. But I think it's really important to not only do exploratory trials, but really think about registrational trials incorporating those biomarkers. Here you see I-SPY 2.2, where indeed those blocks of treatment. So they start, with an experimental arm. You could argue whether that is the right approach, but at least not give everything at the same time. If there is a good response, take patients to surgery, like we did in the Bellini study. If there's no response, give carboplatin paclitaxel, and really give the anthracyclines if it's really necessary. Very elegant design of ICEPOIT 2.2. Last but not least, what is the impact of immunotherapy on long-term quality of life for our young breast cancer patients that we now cure more and more? So here you see the number. So 5% extra cure with Pembro. It's 13% that we give Pembro, but that still relapse. And then it's 82% that we already cure with surgery, radiation, and chemotherapy. So this 82%, the Pembro is over-treatment. The 13%, is it over-treatment or not? At least not a useful treatment for those patients. It's nice to see that the Keynote 522 trial has already published data on quality of life. And the statement of the paper is that adding Pembro is not, affecting quality of life in a significant manner. But I'm wondering if you use the standard PRO instruments questionnaire, whether you pick up those patients with this very severe toxicity, adrenal gland toxicity, diabetes. So it's only rare population with a specific, part of their quality of life that is affected. I'm not sure whether with the standard instruments you pick up this difference in large trial like this. Also important to look, we're talking here about women, young women, and what is immunotherapy doing across, if you compare it with other tumor types, other cancers. And this is a meta-analysis comparing females and males and different treatments. So, and the dots are all at the right, meaning more severe toxicity, this is only grade 3 and grade 4 in women. Of course, women are more vulnerable for autoimmune phenomena, but here you see, and also for targeted treatment and chemotherapy, there's more toxicity. And you see most severe toxicity for immunotherapy in women. Also, if you look at fertility, we don't know much about fertility after chemo immunotherapy. There's this, I think, very important paper in mice suggesting that after immunotherapy, you have less oocyte or less quality of oocytes. We need to study this in a clinical setting. Last but not least, making it a bit complicated, at least for me, how to incorporate this in decision making. So you see across tumor types that there are reports now that immune-related adverse events may correlate with good outcome. And this is puzzling, right? That you have a side effects that you're not happy with, but you might survive longer. So I don't think we should be happy with side effects, but this is, something we, should have a close look on. So this is a poster presented at this San Antonio, and you see 4 groups. It's like PCR, non-PCR, immune-related events or not. And you see that the patients that do best, a PCR and a side effect. It's not specified what kind of side effect. And especially of interest in this non-PCR group, you see the split of the curves enormously. So you don't have a PCR, but you had a side effect. I hope it was a minor side effect. And then your survival is relatively good as compared to a PCR with not a side effect. This needs further thinking, and it's confirmed by other tumor types, why they describe, especially for thyroid problems, that correlates with a better prognosis. So in summary, I think we have a shared responsibility, so industry, academia, guideline committees, to ensure that patients get all the information they deserve to make decisions, to minimize over and under treatment. Biomarkers are important, especially from registrational trials. Altogether, we should limit trials with this multi-phase, so having neoadjuvant plus adjuvant. So it's called contribution of components. You'll see a change there. I pointed out that escalation, also de-escalation, maybe it's a bit tricky word, but giving less without compromising survival is needed, but we have to incorporate baseline factors and on-treatment information, imaging, ctDNA, and on-treatment biopsies, though a burdensome patient, but highly informative. And last but not least, prediction of toxicity, so that you can judge for an individual patient what is the burden of the disease and what is the burden of the possible adverse events. Thanks for your attention.
Thank you so much. Now, last but not least, I'd like to invite Evanthia Roussos Torres from the University of Southern California of Los Angeles, California, who's going to predict for us the future of immune therapy. Welcome.
No pressure, thanks.
No pressure.
Well, thank you very much to the organizers and moderator for having me today to talk about the future of immunotherapy. These are my disclosures. So I'm just going to start by going over the types of immunotherapy, not just in breast cancer, but just generally the types of immunotherapy that exist in life. And then I will focus very much down on some very specific examples of where I believe the future of immunotherapy is headed, and how this is incorporating the different types of immunotherapy. So certainly immune checkpoint inhibition is on the top of the list because this is where the immunotherapy lies in terms of what we do in breast cancer. But there's also vaccines, adoptive cellular therapies, and targeted therapies, which we can't forget about. And there's many, many, usually earlier phase trials that are looking at these different types of immunotherapy and certainly have potential, but just really haven't reached our standard of care in the breast cancer world as of yet. So hence I'm going to spend the most time today talking about immune checkpoint inhibition, since this is where we've seen the most benefit in our patient population. But I just want to recognize that there's a lot of other, there's entire conferences on immunotherapies and specifically immunotherapies in breast cancer, so I certainly can't cover all of that today. But there's a lot of really important modalities that really are going to become more and more important as we discover more and more how to use them in breast cancer. So I think I've had a beautiful setup by my other speakers on the panel about, what do we know about immunotherapy in breast cancer as of now, and what are the approvals? So I'll just summarize them very briefly since we've heard a lot about them, and we all know. Pembrolizumab is the only approved immune checkpoint inhibitor that is used in combination with chemotherapy for both early stage high-risk breast cancer, specifically triple negative, in the neoadjuvant and adjuvant setting from KEYNOTE-522 and I-SPY. And then also metastatic PD-L1 positive triple negative breast cancer in patients with a combined CPS score of greater than 10. And this is from KEYNOTE-355. And these trials and results have led to the FDA approvals in 2020 and 2021, primarily because of the improvement in PCR rate that we've seen with pembrolizumab and the improved EFS and overall survival. However, what we also have heard about is that this comes with toxicity, and in some cases, this toxicity is severe. And so the PCRs that are associated with lower risk of recurrence, possibly we are over-treating these patients. And so we can't, we have to find ways in which we can figure out how much patients really need, because the toxicity is real. And in the patients with residual disease that are associated with high risk of recurrence, possibly we're under-treating, and maybe it's not the right patient population, or maybe we needed to do something different or treat for longer. It's still unclear exactly how we can fix this problem, but these are two problems that need to be recognized, and things we need to use the research to help us find. So can we do better? Of course we can do better. That's why we're all here, and that's what we all do. So first of all, we actually heard some nice discussion already about chemotherapy. Do we need anthracyclines? This is just one question about the chemotherapy. I would also pose the question, do we need chemotherapy at all? And I think in certain patient populations, the answer is we might not. So I'm going to list some trials that are kind of looking into some of these questions, because again, it's not comprehensive, but just to give you a sense of what are the questions that are in our future with regard to immunotherapy. So what about how much is needed and when? So we also heard a little bit about this. Is it just in the neoadjuvant setting that we can get the best responses, or is it also necessary adjuvantly? And the main issue is we don't really know how to tell, and we don't know how to pick the patients who would benefit most. The immunology suggests that neoadjuvant use is going to get us the most bang for our buck, but we don't have any way to predict whether or not we're doing what we've set out to do. So one example of something that's being investigated is looking at early changes in PET-CT to predict PCR. And there are a number of trials that have looked at this in the case when we're using immunotherapy and also not using immunotherapy, to try and just figure out biomarkers in general to help us find out how to guide more personalized therapy. And just in general to say that this is an issue with predictive markers, and this is what we really need more of. And then what about patients with residual disease? So there are a number of trials that are looking at what to do in this case, and there's a lot of different independent trials that kind of guide what we do in practice, whether we're giving chemo, we're giving more immunotherapy, or we're giving PARP inhibitors dependent on the patient population. But we really do still need more guidance especially with regard to immunotherapy, about what we do in the case of patients with residual disease. So this is where I'm going to focus most of my time. How do we improve the anti-tumor response? And this is where the future of immunotherapy lies. If we can figure this out, then we can do this in a very purposeful way. So I've listed 3 main areas of how we can go about approaching this question. Modulating the tumor immune microenvironment to overcome immune evasion, heightening the adaptive immune response, and identifying tumor-specific targets to facilitate and harness the innate immunity. So one way of going about this is looking at immune modulators that have specific targets. And this is, again, not a comprehensive list, but lists some of these specific targets that are under investigation, some in phase 1 and phase 2 trials now, and in combination with other therapies as well, to try and get at specifically the modulation of the tumor immune microenvironment to overcome this aspect of immune evasion. Then there's also more broadly targeted agents that are broadly targeting the tumor microenvironment. And what's listed here are a number of therapies that we already use, and sometimes just don't think of them as immune modulatory, but certainly can and have been proven to modulate the tumor immune microenvironment, such as chemotherapy, altering different doses of chemotherapy, radiation therapy, also given maybe not in the standard manner, but used as an immune modulator, cryotherapy, number of targeted therapies where there's many, many trials now looking at different targeted therapies in combination with immunotherapy, specifically immune checkpoint inhibitors, to do this, to act as immune modulators. Then, of course, there's gene therapy and other types of immunotherapy, which include dual checkpoint inhibitors, specific cytokine therapies, vaccines, different cellular therapies as well, that all fall into this category as immune modulatory, but are typically thought of as more broad targets of the tumor microenvironment. And then epigenetic modulators, histone deacetylase inhibitors and DNA methyltransferase inhibitors, which also target very broadly, but have specific effects on the immune microenvironment in a way that can be very, very beneficial. So now I'm going to talk a little bit about targeting immune evasion to improve response, and specifically how this is done, and what do we have to learn? How are we going to do this? We're tasked with it's a big ask. So immune suppression is one of the largest known mechanisms of intrinsic resistance. And we've heard a little bit about myeloid-derived suppressor cells today, and T-regulatory cells, and tumor-associated macrophages. These are all different suppressive immune subtypes that are known to infiltrate breast cancers of all subtypes in different quantities based on what subtype we're talking about, but they're there. And so what we really need to understand is this mechanism of intrinsic resistance in order to make decisions about how to get around it. So one strategy to do this is to suppress the immunosuppressive tumor microenvironment. And how are we going to do that? And the way that we're currently going about this is looking at novel drug combinations. So the way we're approaching improved anti-tumor immunity is first to combine drugs that are specifically addressing this intrinsic mechanism, and then going after the activation of the T cells and recruitment of NK cells and DCs to actually kill and shrink tumors. So I put the list back up. This is our list of these more broad tumor immune microenvironment targeting agents as categories in which we are combining immunotherapy and specifically immune checkpoint inhibitors with drugs within these other categories to achieve this goal. I'm going to spend some time now talking about an example, which is a clinical trial which we published earlier this year, where we combined dual checkpoint inhibitors with epigenetic modulating drugs to achieve this, to promote an anti-tumor response. And I'm going to describe the results and some of the correlative analyses from this trial to illustrate how it is we can go about understanding ways in which we can improve immunotherapeutic response. So this is an overview of the translational research approach from mice to men with some math and back. And this is just to highlight that a lot of these studies being done in my lab as well as many, many other labs all around the world really kind of embody this. We have to start preclinically, move into clinical trials, and then we have to go back and learn more about the immunology and the basic science that's driving the mechanisms of response, and then we can go back to our clinical trials to do better. And the math piece I just threw in because this is something I've recently learned much more about, and it's a really powerful tool that can really help us both preclinically and clinically to move things along faster. So starting in mice. So this example that I'm going to discuss today is histone deacetylase inhibitors in combination with anti-PD-1 and anti-CTLA-4, which was shown to improve survival in breast cancer mouse models at first. The first model was triple negative 4T1, which was shown to eliminate the breast tumors when it was combined with epigenetic modulator and a DNA methyltransferase inhibitor, and was shown to improve survival. So then we tried it in a HER2-positive aggressive mouse model and saw very similarly that it improved, it shrank the tumors and improved survival. So that was enough to move into a phase 1 trial. You know, that was 6 or 7 years of work, so it wasn't super quick, but it was enough. So we launched a phase 1 trial in patients, and we started with a dose escalation cohort, established a recommended phase 2 dose, and found that adverse events were acceptable as they compared to other trials that had looked at similar drugs. And then we did a dose expansion cohort in advanced breast cancer, which demonstrated efficacy. And to give you some specifics about how patients were treated in the breast expansion cohort, these were advanced HER2-negative breast cancer patients with no prior immune checkpoint inhibition. They received a 2-week run-in with entinostat, and then they got nivolumab and ipilimumab together for subsequent cycles. There was blood and biopsy taken at 3 time points. And what we found was, and of note, this was a heavily pre-treated patient population. It ended up being 10 evaluable hormone receptor positive patients, 10 triple negative patients, that with a median of 6.5 prior lines of therapy. And again, a very small cohort, so you know it's more exploratory. But just to give you a sense of what the potential is here, is that we had an overall response rate of 40% in the triple negative breast cancer cohort, which is 4 patients out of 10, and 10% in the hormone receptor positive cohort, which was 1 out of 10. Clinical benefit rate was 35%, and the response in this case was not correlated with PD-L1 expression, tumor mutational burden, or TIL. And we heard a lot about these as biomarkers. So this is a common story. In many cases, we do see correlation, and in many cases, we don't. So the progression-free survival in the triple-negative breast cancer cohort was 9.6 months. Overall was 18.2 months. You could compare these to some of the amounts of time that were seen in some of these larger trials that were actually powered to detect efficacy. This was not, but at least has some similarities. So the point of this is to show that it's the combination of targeting immune evasion and immune activation, the immune evasion being targeted by the histone deacetylase inhibitor in this particular case, and immune activation by the immune checkpoint inhibitors that led to a response. So now we really need to, our future really depends on understanding how this works, because that's how we're going to figure out what our targets are. How are we going to do better? Or is it just that we need a better patient population, not better, but more appropriate to find out who will respond? So back to the mice. So at first it was that myeloid cell modulation was found to contribute to the response in the breast tumor microenvironment. In the triple negative model, it seemed that you were actually just decreasing your MDSCs, and that actually and that response in this case was dependent on specifically just the Ly6G positive cells. In the HER2 positive model, which wasn't represented in the patient cohort, but in the mice we do have ongoing studies, it was actually not a change in the number of infiltrating myeloid cells. It happened to be a change in their immunosuppressive function, that you actually prevent the suppressor cells from suppressing, and that's how you're actually leading to improved T cell activation. Further studies actually found specific decreases in cytokines that were responsible for this response. But the problem here is, what about the other immune cells that are participating in immune evasion? I highlighted that there were Tregs and macrophages, and there's others as well. So the problem with how we do a lot of these studies in the lab is, you have to have a hypothesis and go after a specific cell set. But now we have a lot of technology that allows us to really understand what else is there. What's the big picture? Are there new and better targets? Are there biomarkers that maybe could be useful for screening or response? So we went back to the mouse models, and we did single-cell RNA sequencing. And what we also wanted to make sure that we did was really represent what we're the patient population that is being studied here. This is a metastatic patient population. So we really felt it's important to study the immune infiltration in the Mets. So we developed a highly metastatic model that spontaneously metastasizes to the lung, and we're working on one that goes to the liver, with large enough Mets that you can actually macrodissect and study the immune cells within the Mets themselves. And so we did that, we developed the model, we published this and made sure that the model in this particular case responded similarly to our patient population if we wanted to use this for discovery. And so then we went into these Mets and we used something called cell chat analysis, which is an analysis done on single cell RNA sequencing to identify the different populations of immune cells that are reprogrammed and perhaps having chats with each other, and how these could be understood to be changed by the treatment. So this type of analysis identified T cells, the granulocytic myeloid-derived suppressor cells, macrophages, dendritic cells, and lipofibroblasts that are specifically reprogrammed by HDAC inhibition. So then we took out all of those specific populations of cells from these Mets, and we put them into co-culture to ask, how do they suppress T cells? That's what they're known to do. When we take them out of the Mets themselves, do they do what they're thought to do? And so what we found in our system is that the GMDSCs, the lipofibroblast, and a specific subpopulation of macrophages from untreated metastases suppress T cell proliferation. So then we went back and we said, okay, so they ultimately suppress when they're without treatment. That's what they do at baseline. When we give entinostat, or that's the E here, or PC, which is just the dual checkpoint combination, or the triple combination, which was our winning drug combination in our patient population. What happens to these interactions? So these are the kinds of plots that you get when you do cell chat with single-cell RNA-seq. Every single small, colorful dot represents a different subpopulation of immune cell. So you can, if you just take a step back, you can certainly appreciate that when you give entinostat, you change how those circles are connected and which circles are connected. When you give dual checkpoint, that looks somewhat more similar to vehicle, but does change a little bit. And in the winning combination, it does look closer to after having treated with just entinostat alone. But what you can fully appreciate regardless is that the cells that are chatting are different, and the strength of those lines, which represent the strength of the signaling, also changes. So then we asked, okay, there's still an overwhelming amount of information here. How are we ever going to figure this out? How are we going to get our new targets or our biomarkers? So then we did an analysis that's called a motif analysis. It's a cell circuit analysis to actually help narrow down from 16 different cell types that actually it's the 2 or 3 cell motifs that are the most chatty. And of those, you can actually rank them and identify, of the 16 cell types that were input in this analysis, which 3 are the most chatty and have the most effect by the winning therapeutic combination. So we did that, and what came out was, after entinostat and then what is actually preserved by the treatment with the triple combination, is that it's macrophages, the GMDSCs, and the T cells, in fact, that are the most significantly affected by treatment. So even though our earlier studies had been somewhat more of an educated guess as to which cells were important, it turns out that at the very least we were on the right track. But now we can say with much more confidence that after having looked at all of the cells that are within the metastases, in fact, yes, these are the most chatty and the most affected by treatment. So now we want to know what ligand receptor pairs are driving these changes in chats, and we can rank these. And so I'm giving you an example of 2 different ligand receptor pairs that came to the top of our list. One is ICAM1 and one is galectin-9. What you can see here is in the ICAM1 example, when you give entinostat and when you give the triple combination, you really decrease the strength of the signaling through this ligand receptor pair. Whereas with galectin-9, it's the opposite. It's increased with entinostat and maintained in your winning drug combination. So then, this is exactly what we were hoping to be able to do. Oh, we can get this list, we have targets. Maybe we can just, maybe these are the winning targets and we don't have to give these broad, immune modulatory drugs, and we can add, some of these targets to that list that I showed you earlier of more specific targets. So the next step is to actually, interrogate these. So we started with one that made the most biologic sense. ICAM1 is intracellular adhesion molecule 1, which facilitates contact and interaction between T cells and macrophages. So we pulled out our cells from the metastases and put them back into our T cell suppression proliferation assay, where you have two cell types, you put them together, and you actually ask about suppression of T cell proliferation and look at a change in fluorescence as a measure. And when we did this, and we added a blockade of ICAM1, and what we saw was that we actually rescue a specific subpopulation of macrophages, the MHC2 low macrophage mediated T cell proliferation, and there is actually no effect on the GMDSC suppression. So blockade of ICAM1 does have an effect on the T cell suppression from these specific cell subsets within the tumor, but it's still definitely, I'm sorry, it was too fast. It still doesn't seem to be that robust. Just to do due diligence and see if, okay, well, maybe this assay wasn't, this is something, it definitely explains part of it. What is happening in the patient tumors? Can we get a sense that maybe, since ICAM1 brings the cells together, it's basically the glue between this macrophage and a T cell, is it maybe in vivo and in patients, maybe it is enough? So we looked in our patient cohort, we did imaging mass cytoph, and we looked at the location of macrophages and T cells in responders and non-responders. And what we actually found is in our responders, the distance between the macrophage and the T cells is statistically significantly farther away after treatment, and the cells actually don't move away from each other in our non-responders. So that actually does support that there is ICAM1, this phenomenon may be contributing to the response. And then we looked at bulk RNA sequencing from our patients and actually found, in fact, there are statistically significant changes in gene expression in specific T cell subsets, which does indicate that we're changing the signaling going on as indicated by our cell chats from our mice. So as we heard at the very beginning of the meeting here at San Antonio, really we have to know about whether something is sufficient. Is it sufficient? Is this ICAM1 blockade sufficient to get a response? And what we found when we did this, when we went into our mice, we blocked ICAM1 and say, well, if we were to just block ICAM1, do we get what we get when we use this broad epigenetic modulating drug? And the answer is no. So it's not sufficient. So even though we're like, oh, we discovered this cool target, it doesn't seem like this is gonna be enough. This is not sufficient. So how on earth are we going to identify whether individual or combined cellular targets are necessary for a response? And how are we gonna work through our list of hundreds of ligand receptor pairs in numerous different immune cell types? So we turn to our math colleagues. So this is work being done with a collaborator who's a computational biologist, Dr. Adam McLean, he's at USC. And I went to him, I presented this work at a meeting, and I said, I really don't know what we're gonna do. This is gonna take 5 years to work through. My poor graduate student will never graduate. So he said, maybe we should try math modeling. So we developed a model whereby we took the tumor cells, and in this particular case, an MDSC. We have the model also being done with macrophages. So one of the suppressor cell types with the tumor cell and our anti-tumor cells, our T cells and our NK cells. And he developed stochastic differential equations that each equation represents a different cell type. And within each of the equations, each of the parameters that inform and that are worked into the equation are representative of what the cells do. So each of those different Greek characters represents either proliferation of the MDSC or suppression of, or secretion of arginase 1. And these can all be tuned within these different equations to represent how they interact and their effect on each other. And so then what we did was we input the information that we learned from our single-cell RNA sequencing, i.e., the changes in expression of ligand receptor pairs in one direction or another, and their effects on these different cell types, and these were input into the math modeling. And we asked of the model, how does these change in these parameters, specific to those ligand receptor pairs, affect tumor cell growth? And what we found was that it's not just one parameter. It's multi-parameter interference that's necessary to actually shrink a tumor. And in this particular case, those parameters were alpha-6 and beta-4. The alpha-6 representative of MDSC inhibition of CD8 T cells, and beta-4 being the increased activation of CD8 T cells. So, will blockade of narrowed targets induce response, or is broad inhibition of HDAC1 and 3 necessary? In this particular case, I think the answer might be that broad inhibition might be necessary. I think the question is still unanswered because now we actually have 2 parameters in which we can more specifically test and investigate. It is still possible we could find more specific targets. But in this particular modulation of the tumor microenvironment, it might be that we need the HDAC inhibitor. So in summary, the broad effects on the immune TME, at least in the example I gave you via HDAC inhibition, may be needed to induce changes in immune evasion. The search for narrower targets that are sufficient to achieve improved response is ongoing, and use of mathematical modeling can hasten mechanistic findings and should be used to guide preclinical and clinical research. And I think this is a really important point when it comes to the future of immunotherapy, because there are so many different types of immune cells. They change constantly, and the microenvironment in which you're studying them changes how they function. So we really need ways in which we can do this that doesn't take years and many different graduate students per immune cell subtype. And then the real take-home message here is that it's really the future of immune checkpoint inhibition really lies in novel combinations that are targeting immune evasion to improve response rates. So what are the next steps for targeting immune evasion? So there is this question, at least in this particular example, about dual checkpoint, and this was brought up by others as well. Is there a role for treatment with anti-CTLA-4 in breast cancer? Is dual ICI with other checkpoint inhibitors needed for response? So we're doing a meta-analysis right now, actually. Dr. Santamaria and I are doing this together with others in the room as well, looking at 10 trials that use dual ICI in breast cancer, and we're trying to figure out, is there a signal there? What can we learn from these trials that have been done? And then also investigation of additional ligand receptor pairs and immune cell changes as biomarkers for screening and/or response. A lot of the work that can be learned from some of the basic science and immunology actually has a lot of potential for use as biomarkers, and we really need to embrace this and try and understand how it can help us. And then investigate immune cell changes induced by other successful tumor microenvironment modulators to identify universal mechanisms. So the future of immunotherapy, at least for immune checkpoint inhibition, likely lies in combination therapies, at least where in the breast cancer world. And then as the other forms of immunotherapy that I've mentioned, vaccines, adoptive cellular therapies, and targeted therapies, they also fit into the story that I told. They also modulate the tumor immune microenvironment to overcome immune evasion. They also heighten the adaptive immune response. So these are the questions coming from the immunology side of all of the different forms of therapeutics that will really help us to push this forward and figure out how to use this in the world of breast cancer. So these are the acknowledgements. Of course, I want to thank patients and their families, not only for participating in the clinical trial that I showed you that my group participated in, but all the clinical trials you've seen today are not possible without the patients and their families. And then the members of my lab and the numerous collaborators that have gone into a lot of the work that I showed you today. And of course, all of our funding, AACR, BCRF, Tower and Concern, all of these foundations whose support we couldn't make these strides without. Thank you very much.
Thank you. So at this time, we have approximately 15 minutes for question and answer. So I invite you to go up to the microphone. Those of you in the audience, there's one on either side. And for those of you who are online, please feel free to submit your questions online. I'll take the prerogative as people are going up to the microphone potentially to ask the first question. And I should probably disclose, actually, as the chair, that I was involved in several of the studies that were mentioned, the Checkmate 7FL, the Keynote 756, and the Keynote 522, so just for full disclosure. I'll start with you, Dr. Santamaria. You mentioned the 2 immune therapy early stage studies, Checkmate 7FL and Keynote 756. It's worth noting that the Checkmate 7FL study was originally designed with co-primary endpoints as a registrational study with both PCR and event-free survival. When the Monarch E data was reported, a decision was made by the sponsor to drop the EFS co-primary endpoint and enroll a more modest number of patients. So that will not be a registrational effort, most likely as a result. So the Checkmate 756 study is really the only study that I think is in line to become potentially a health authority approved study. So I would ask you a couple things. Number one, do you think that 8.5% improvement in path CR rate is going to translate, if you can just use your crystal ball for me, is that going to translate into event-free survival advantage? Because we don't typically think about that correlation for hormone receptor positive disease. And then by extension, how will we reconcile, assuming that there is an event-free survival advantage, how will we reconcile with the CDK4/6 data given all the issues of toxicity, hepatitis, pneumonitis with co-administration of checkpoint inhibitor therapy and CDK4/6?
Great question. So, yeah, I think there's a lot of factors that can affect the relationship between PATH-CR and event-free survival. I think most notably in the ER-positive space is going to be the adjuvant therapy that's given, where for high-risk patients, we would think about treating them with adjuvant CDK4/6 inhibitors, and how could that potentially affect outcomes? In the 756 study, there was an adjuvant phase to the pembrolizumab, so I don't believe any, or at least most patients did not receive CDK4/6 inhibitors. So I think
nobody did on that study,
yeah,
correct?
Exactly, yeah. So I think the magnitude of benefit is one of the things we're going to have to look at to reconcile, how to potentially sequence these therapies. With the approved adjuvant CDK4/6 inhibitors, ribociclib and abemaciclib, indeed, the toxicity with immune checkpoint inhibitor is quite significant. So I don't think those would be drugs that could be combined. In the studies with palbociclib that I demonstrated, the toxicity profile was much less, but palbociclib is not used in the adjuvant setting. So I think those would be things that would need to be reconciled.
And even sequencing will be tricky, right? Because you can have delayed immune-related adverse events even a year after last exposure. And so what's the optimal timing of any sequencing?
Yeah, and I do think the jury's out in terms of what adjuvant immunotherapy does in breast cancer.
So I'll go to the microphone on my right. I think it's Laura.
Yes, Laura Bates here. So, of course, I have a question about biomarkers, but biomarkers of different sorts. So I think it was a fascinating session, and there have been other presentations throughout the meeting on immune therapy and what to do. I mean, if you keep listening, I'm listening, okay, what do I need to do? What can I do? And you have maybe probably all the same. I think it's a combination of things. It's both understanding the tumor biology, the microenvironment. It is the direct change in the immune system. Some people measure that in how clonal become T cells in the blood. Others will look at macrophages. There are different combination therapies one can choose. Some do it with CDK4/6 if you're in the lower risk area. Others may add a second immune therapy. So I think we need to come up with a system that everybody is starting to measure the same things, because otherwise we're all talking to each other like, we need to do TILs, we need to do a gene expression biomarker, we need to do... So I think maybe one of the things we can do sometime in the near future is think about that we all measure things in a similar way and find out, is it like the biology of the outset of the tumor? Is it the immediate change? I mean, it's a fascinating time, and with your modeling that you brought in, I think that's what we need. So you need to measure and then see which of these parameters is changing that will tell me who is responding. I don't have the answer, you maybe don't have the answer, but we need to sort of come up with a consensus what we're going to measure is my point. What do you think?
I don't know if you want to comment on that, Evanthia.
Yeah,
And then by extension, the call for collaboration, but also by extension, I mean, to me, it makes sense to target different aspects of the cancer cell immunity cycle. And I'm excited about the data that you presented with your triplet therapy, CTLA-4, PD-L1, and HDAC inhibitor. how will we manage the toxicity with triplet therapies in the clinic, do you think?
Yeah, so these are great, really great points. And I think as of now, most of the trials have been doing measurements of PD-L1 and TIL and tumor mutational burden, because those are sort of the canonical markers of immunity. And so we can usually, typically find those. And I think it's still important to recognize that there are certain subsets of patients in whom those correlations really matter. So I think continuing to do those makes a lot of sense, especially since they're things that most labs can carry out. But I think in the age of all of these new spatial transcriptomics, and even what we saw with the with the updated correlatives from Keynote, where you can actually get predictions of much more granular subsets of immune cells using the transcriptomic data. And then on top of that, because now we can do the spatial transcriptomics, we can do staining and get information about protein and cellular positions and identities. I think it's going to be important to really do those types of correlatives, because I don't think we have an answer yet. But as you can see, more of the myeloid subsets are coming into play here, and I think we're getting closer to having better biomarkers. But I think we're in that hypothesis generating stage where in all of the trials that are going on now, we should be doing the canonical markers, but I think we really need to invest in doing some of these more exploratory correlative analyses to find what those next biomarkers really should be.
Yeah, I think, Laura, so last year I left a meeting together with Andy Tutt, who is of course an expert in triple-negative breast cancer, and we had exactly your feeling, like we do a lot, but we all do it in a slightly different way. We have our favorite technology or some money related to a certain technology. But to have a blueprint per subtype for the bare minimum that a trial should report, and besides, hypothesis generating, highly complex, I think that will really benefit the academic community, and that you can also say to certain pharma trials, this is the bare minimum, and thereby you benefit the patients, and it helps bringing a biomarker to the clinic. I think it's critically important that as community we start writing such a simple blueprint of what is really necessary.
Might be. Plus, I think to think about who needs this dual targeting or triple targeting, or does it need to extend to like 5 months after surgery, or who can do 4 months is enough or 3 weeks is enough. I mean, there are lots to do.
Yeah, and just to address the toxicity. Yeah, because the toxicity issue, this is the point, right? How long do we need to do each of these therapies? Do we need all of them? In this particular trial that I was reporting on in ours, the toxicity, I think the reason why it actually was more tolerable than you would have expected is because it was very limited. So, patients only got 4 doses of IPI and then it was done. And and then the Nivo was tolerable, and Tinostat actually also was at a very low dose. And I think what part of what I was alluding to in some of the earlier slides is just that sometimes to get the immune modulatory effect, you don't need the same doses or the same number or the same concentrations of doses. And so I think that's something that we really need to think about. If our goal is immune modulation and not necessarily the same effect on the tumor cells themselves, we can achieve that with much lower doses and less dosing, not only number of doses, but time. And I think that's something we need to think about.
Which makes sense, because the conventional thinking being that CTLA-4 targeting is an activation, so you get the T cells revved up, and then PD-1, PD-L1 prevents them from getting exhausted. So it makes sense that once they're activated, you don't need to consistently continue to activate them. Microphone on the left.
Thanks. Nick Murray from Adelaide. So staying with toxicity, I was interested to hear the suggestion that perhaps we could be moving from chemoimmunotherapy to immunotherapy alone as something potentially attractive. In the last 6 months, I've told 2 young women who had cancers that were potentially curable by chemotherapy alone that they now have diabetes and they're going to have to inject insulin for the rest of their lives. That's not all I've seen in those 6 months. And it just worries me that we're looking at toxicity A as the same as toxicity B, and some of these immune toxicities are catastrophic.
Yeah, I think it's an excellent point that, we tend to report like grade 3 and grade 4, but the endocrinopathies usually score a grade 2. And thereby, not only in breast cancer, it's not that they are ignored, but they are not reported with special interest. Well, those are the ones on having a long-term effect. And I think, every immunotherapy trial should report those events and to also do a proper follow-up. I think in the earlier trials, or even maybe in the keynote 5-2, if you don't do proper follow, you don't find them. And they should be reported also on the long term. Yeah.
These are life-changing and life-shortening toxicities.
I will just say, I think that was one of the ending points I made for the ER-positive section as well. A lot of these patients are potentially curable with standard therapy, and they really do not need those immunotherapy toxicities. So identifying a higher risk population that justifies the potential toxicities is a really important part of this as well.
And I think, Marleen, you made a really good point, which is that it's not just about the immune-related adverse events. We have no idea what the impact is on fertility, and we treat a uniquely young population with these strategies. To my knowledge, the Optimize studies that are looking at escalation and de-escalation strategies, for lack of a better term, are looking at impact of immune therapy on fertility. So more to come on that. Microphone on the left.
Thank you for that session. That was lovely. We were part of the 756 trial as well, the keynote 756, and had seen some really incredible PAT CRs in some of these locally advanced, what were luminal B-like cancers. Perhaps that's the niche area as we have adjuvant CDK4/6 that take over high-risk patients for adjuvant therapy. There might be a niche population, I suspect, that we should look at genomic profiling to pick out who might benefit from preoperative immunotherapy in the ER-positive, HER2-negative subset.
Yeah, I think gene expression profiling can serve two purposes, not only to identify that higher risk population where you potentially would be okay with considering the toxicities of immunotherapy, but one of the slides I showed was a presentation from ASCO earlier, how mammaprint high 2, kind of the upper end of mammaprint, these tumors are particularly inflamed. So mechanistically, there might be a for that as well. So I think that could be helpful stratification as well.
And just to add to that, low-hanging fruit, even without the level. So ER-positive is big. Well, maybe this cutoff of 1% or 10% is if you talk about immunotherapy. I think ER low, ER are the things, and measuring start to tease out who might benefit together, of course, prognosis.
Mm-hmm. Maybe a provocative, and by the way, I love the these immune therapy strategies, curative intent setting in the right population of patients, because I to have forgotten that in the first negative breast cancer setting, of patients respond to checkpoint inhibitor alone, more than one monotherapy study, and these strategies are more in the curative intent setting. Explore immune therapy alone. But stakes are high, and I did get a question from one of the audience members for de-escalation. Given the cyclins, particularly in no breast cancer, we have no predictors of response, and those who don't response, a third of those recur of metastatic disease. Given your own tonic data, that maybe anthracyclines are the best as an induction strategy part for checkpoint inhibitor therapy, really ready for studies that forego in this high-risk population.
For all comers, here, right? That if we consider it one disease, and it really matters, the matter of the amount of inflammation and of the lymph node. So de-escalation, but if we can tease out at baseline. You know, there are some patients that don't need 4 chemos and immune, but you have to find, and to have the courage to not do comers. I think that's done. Yeah, but you de-escalation, everyone, but for specific patients, it's important to study.
And there are a lot of in online about biomarkers. Have any answers about the options to select for patients potentially TILs? But by extension, what is your current thinking? And this sounds like sort of, but I think people are struggling with this a lot. How are you thinking about the fact that immune works in a PD agnostic population and setting in both triple negative and breast cancer? So another target is lacking, and we saw some of the presenting showing that if tumors were more enriched for PD-L1, the benefit was still an almost 5% improvement who were PD-L1 negative. If the target isn't there, how are the strategies? Why is it a different curative intent versus the anybody wants to take?
Yeah, I can start. Yeah, so I think it's a totally different, the metastatic triple negative. There you enrich for cold tumors. And I think, you have this mixed bag. Also, I think therapy is not a targeted disease, so the PD-1, it's just a for immune activation. Suboptimal readouts. Those are important to consider. And I've seen data on PD-L1 level, PD-L1 on certain. I think the data from Neotrip is important that if you do both PD-L1, but if you can on certain cells might be highly informative. Those elements are important to consider, but happy to hear your answer.
Though, just to riff on that a little bit, 5 experience, even the static, so untreated seemed to be the same set of rules. So that even in an that they would behave differently.
But so the tumor has escaped the immune system. I think the basic difference that the system is not able to give tumor control. While I think high TIL tumor, it's an endogenous immune response. Difference in triple negative.
Cesar?
I'll just in a static setting, there is homogeneity in terms of immune landscape. So, for example, metastases tend to be in terms of some of the classic immune bio. I think there's more heterogeneity there.
And then I would just add that the other thing to think about is what are the immune cell types that are expressing the effect of PD-1 or PD-L1 blockade, even if primarily T cells and/or tumor cells. The other cell types in significant, especially if you start the myeloid infiltrated tumors. It's not really being accounted for when we test for PD-L1 status. The other thing is many of the times we're checking for PD-L1 baseline, and most of the time we're not seeing how PD-L1 expression changes with treatment. And the PD-1, PD-L1 axis and numerous other checkpoints can be up and down regulated. So it's changing. It's a moving target, actually. So I think it's a little bit. I think we're being misled a little bit by just checking baseline status and associating responses with that, whereas it actually is something that maybe the patients who are able to upregulate or downregulate, for that matter, that checkpoint would have a better response, and we're not capturing that at all.
Yeah, and there's some emerging data that it's not just the presence or absence of PD-L1, it's whether PD-L1 is actually in an activated form. So you can have inactivated PD-L1 that wouldn't necessarily confer a benefit. Last but not least, Josh Gruber, do you want to ask your question?
Yeah, so I just had a question about what's the best way to do drug development and move potential therapies into the neoadjuvant setting where they're more likely to be effective in an efficient way. And how many therapies, potential novel combinations are we losing by testing in metastatic patients that have very little chance of having an immunological response? So could there potentially be a role for testing some of these immunological therapies in healthy volunteers, mainly just looking at circulating biomarkers to confirm activity, and then using that data to quickly move into neoadjuvant?
Well, yeah, I'll start. I think it's a very interesting concept and very provocative, actually. I think part of my bias is that even when you're looking at, pick your favorite immune cell type, even a very like a specific subset, it varies based on where which organ you're looking in. If it's the primary breast versus the lung versus the liver versus the brain versus the bone, the same exact cell can do different things based on what met it is growing in. So I would worry that certainly it would make sense to look in patients who have early stage disease, and that's part of why the neoadjuvant trials are so attractive. But I would worry if we look at it in healthy volunteers, that the tumor changes the immune response, and it wouldn't be reflective of what we would see in a patient population.
All right. Well, with that, I'd like to thank you all for joining and for your engagement. Thank you for these terrific talks today by these tremendous experts, and enjoy the rest of your meeting. Thank you.